Hi everyone, I'm Dr. Aladdin Sagar, and you're listening to This Week in Pulmonary and Critical Care Medicine. I've been thinking lately about how quickly practice evolves in our field. Sometimes it's not the landmark trials that shape our daily work, but those smaller, practical studies that quietly shift how we manage patients at 2 a.m. in the ICU or how we approach a biopsy in someone frail. In this episode, we're looking at one of those questions that sounds deceptively simple. Does the ventilator mode really matter? We'll also unpack why extubation doesn't always happen when it should, explore an increasingly popular surgical technique for ILD biopsy, and end with a new national ECMO emergency guideline that's likely to influence practice far beyond the UK. As always, everything discussed here is for educational purposes only. Let's dive in. The first study tackles a deceptively simple question that many intensivists have strong opinions about, but surprisingly little evidence to back up. Does the initial ventilator mode actually matter for patient outcomes? More than 500 critically ill adults on mechanical ventilation were randomized by monthly clusters to receive one of three common modes during the first phase of invasive ventilation: volume control, pressure control, or adaptive pressure control. The results may seem underwhelming at first glance. The number of ventilator-free days through 28 days was essentially the same across all three groups. Mortality, length of stay, and major adverse outcomes were similar too. No clear winner emerged. But this is one of those situations where the absence of a difference on paper doesn't mean there's nothing to learn. When they looked more closely at the actual delivered tidal volumes, a pattern emerged. In pressure control mode, patients more frequently received volumes that exceeded lung protective targets, even when the intention was to stay within a safe range. Volume control and adaptive pressure control, on the other hand, allowed tighter adherence to lung protective volumes. That matters clinically. A ventilator mode isn't just a setting, it's a guardrail. It shapes how easy or how hard it is to deliver what we know works: low tidal volumes, controlled pressures, and consistency. Pressure control can still be useful, for example, when managing patients with significant asynchrony or situations where pressure limitation is paramount. But it requires much closer monitoring and alarm management to keep things safe. The accompanying editorial put it succinctly: you can only control what you actually set. Modes like volume or adaptive pressure control give you more predictable control over what the lungs receive. Pressure control can be excellent in experienced hands, but it's less forgiving. For bedside practice, this doesn't mean one mode should replace the others. It does mean that if your unit relies heavily on pressure control, you need strong processes to make sure volumes stay within target. And if you're looking for simplicity and reproducibility, especially in busy or resource-limited settings, volume or adaptive pressure control might make protective ventilation easier to deliver reliably. Now to a different kind of ventilation problem. Not how we ventilate, but how long we keep people ventilated unnecessarily. This large retrospective analysis, published in the Blue Journal this month, looked at thousands of mechanically ventilated patients who successfully passed a spontaneous breathing trial. And yet, more than a third of them were not extubated within 6 hours, despite being physiologically ready. That delay wasn't harmless. On average, these patients spent 2 additional days on the ventilator compared to those extubated promptly. Those extra days accounted for roughly a third of their total ventilator time. The reasons were telling. Many delays were system-driven: procedures scheduled later in the day, waiting for OR slots, or coordination between teams. Others were related to sedation and neurological status, low vasopressor doses, and secretion burden. All common, all fixable. This is the kind of study that doesn't require a fancy new drug or device to change practice. It simply shows us where time is wasted and where risk accumulates quietly. Every day of unnecessary ventilation increases the chance of VAP, delirium, deconditioning, and ICU stay. The takeaway here is straightforward. Extubation delays are a modifiable target for quality improvement. Creating a culture where passing an SBT triggers a structured extubation pathway, rather than just sitting on the ventilator until tomorrow, can meaningfully reduce ventilator time and downstream complications. Let's shift gears to a procedure that many pulmonologists and thoracic surgeons are re-examining closely: lung biopsy for interstitial lung disease. Surgical biopsy can be high-yield diagnostically, but it carries a real risk in patients who are often older, frailer, and already gas exchange limited. A French center compared standard, intubated, video-assisted thoracoscopic surgical biopsy with a non-intubated technique, essentially performing the surgery under regional anesthesia with the patient breathing spontaneously, supported by mild sedation. The results were striking. Patients who underwent non-intubated, video-assisted thoracoscopic surgery had better preservation of lung function after surgery. Their postoperative FEV1 and FVC were higher compared to those who underwent conventional intubated procedures. They spent less time in the OR, had shorter hospital stays, and needed less postoperative pain management. Importantly, the diagnostic yield was similar between the two groups. On paper, this sounds almost too good, and that's where the editorial was valuable. It reminded us that these patients were carefully selected. They tended to have lower BMI, better respiratory reserve, and fewer comorbidities. Not everyone with ILD is a candidate for this approach, and the timing of follow-up lung function tests wasn't perfectly standardized, which introduces some uncertainty about the magnitude of the benefit. Still, the concept makes biological sense. By avoiding intubation, one lung ventilation, and the mechanical stress associated with general anesthesia, you may be sparing fragile lungs from a secondary hit. And because these procedures often aren't curative but diagnostic, reducing procedural trauma is meaningful. For experienced centers, this is a technique worth considering, not as a replacement for intubated, video-assisted thoracoscopic surgery, but as an option for carefully selected patients, particularly those at higher risk from mechanical ventilation. For others, it's a reminder that even routine biopsy can be refined to reduce physiologic insult. ECMO emergencies are some of the most intense moments in critical care. The usual resuscitation playbook? It doesn't apply. There's no reliable pulse to guide you. End-tidal CO2 can be misleading, and when the circuit fails, things can unravel in seconds. That's why a new UK national guideline is so important. It brings structure into what's usually chaos. Instead of vague troubleshooting, it lays out a clear, step-by-step algorithm for ECMO emergencies. It starts with something simple but decisive. A map below 30 millimeters of mercury is the trigger. The moment you call this what it is: cardiac arrest on ECMO. From there, the response splits into two focused teams, one for the patient, one for the device, led by a single team leader. The emphasis is on acting early and precisely, confirming true flow loss, identifying oxygenator or circuit failure, maintaining perfusion. No guesswork, no shouting across the room, just a coordinated, deliberate response. This matters because ECMO is growing fast. More hospitals are running programs, but not all have deep bench strength or after-hours expertise. A standardized, nationally endorsed algorithm means teams everywhere can speak the same language under pressure. It builds muscle memory, and this isn't just a UK story. This kind of structure sets a training framework that other countries can adapt. It's a step toward a safer, more predictable way of managing the most unpredictable moments in ECMO care. For intensivists, it's a good moment to look inward. Are your ECMO teams truly ready for these scenarios? Are the roles clear? Is the response crisp or improvised? This guideline doesn't just tell us what to do. It pushes us to be ready. So, what do we walk away with this week? Ventilator mode may not change survival, but it changes how easy it is to stick to lung protective strategies. That's not nothing. That's the difference between relying on vigilance versus building safety into the system. Extubation delays are a hidden but important source of unnecessary ventilator time, and they're fixable. Non-intubated VATS is emerging as a valuable tool for selected ILD patients, offering lower physiological insult without compromising diagnostic yield. But like all good ideas, it needs judgment and infrastructure. And finally, ECMO emergency response is maturing with structure, clarity, and shared language. That's a big step forward for patient safety. Thanks for joining me for another episode of This Week in Pulmonary and Critical Care Medicine. If this helped you stay up to date, consider sharing it with a colleague or a trainee who might find it useful. I'm Dr. Aladdin Sagar. See you next week.